Good afternoon, everyone. I'm Cindy Gavin, founding executive director of Let's Win, and I'm honored to kick off today's Let's Learn webinar on behalf of Let's Win Pancreatic Cancer and our partners from the National Alliance for Hispanic Health. Before we get started, I want to thank our sponsors, AstraZeneca, for supporting this important initiative. We are incredibly grateful for your support. Today's webinar is the second of a three-part series focused on risk factors and symptoms. But before we get started, I'd like to tell you a little bit about Let's Win. Let's Win Pancreatic Cancer launched in 2016 as an online program to break down the barriers between and help patients get access to the best treatment options for pancreatic cancer. Our three main goals are to help newly diagnosed patients find the best treatment options and manage the disease, to raise awareness about risks and symptoms and educate those at higher risk for this disease due to either a family history, a genetic disposition, or newly onset diabetes. And we also provide much needed hope and inspirations to families. Since inception, we are proud to say we have published over 750 unique science-based stories and featured the work of over 200 medical professionals from over 100 different institutions. We have also shared the voices and stories of 200 patients and have over 65 long-term survivor videos. All of this information is available in both English and Spanish, and everything is vetted by a medical professional. I would also like to introduce our partners from the National Alliance for Hispanic Health. Our friend Marcela Gaitan apologized. She had a family emergency and she's unable to be with us, but she sent her best wishes. A little bit about the National Alliance for Hispanic Health. It is the premier science-based and community-driven organization that focuses on the best health for all. Community-based members provide services to more than 15 million Hispanics throughout the United States every year, and national organization members provide services to more than 100 people nationally. The Alliance works to ensure that health incorporates the best science, culture, and community. At this time, it is my privilege to introduce our moderator and Let's Win board member, Juan Pellerano-Rendon. Juan is a first-generation Hispanic American of Dominican and Colombian descent who works in the marketing and tech field. Juan, take it away.
Thank you so much, Cindy. It's been truly an honor and a pleasure to serve on the Let's Win board, and just furthering that today by hosting today's informative session, right? So today we're going to be focusing on the risk factors as well as the symptoms for pancreatic cancer. We're excited to have two expert physicians today who are really going to dive deep into these main risk factors and key symptoms, because it can really be a spider web of different things that you try to piece together to figure out what's really happening and do I have pancreatic cancer? So after the discussion, we're going to follow that up with a Q&A session. So please put your questions in the chat. And then a survey to provide feedback will be sent to everyone who registered. So really appreciate your participation there as well afterwards. So really important to talk about the people that we've lost also with pancreatic cancer. Most recently, John Lewis, Justice Ruth Bader Ginsburg, Alex Trebek, Aretha Franklin. Even just yesterday, we lost Richard Roundtree, the lead in Shaft, to pancreatic cancer, and as well as my mother, Marta Rendon. My mother was a world-renowned dermatologist, as an educator, global lecturer, also pioneering researcher, published many papers, president of Women's Derm Society, president and founder of American Society of Aesthetics, Dermatology, and Surgery, and president of Skin of Color, and member of the Belizean Grove. And her story was one of many obscure symptoms. She was constantly chasing this lack of sleep, and over a number of years did many different sleep tests, and does she have sleep apnea or not. And one day she discovered that she was jaundiced while examining a patient, self-admitted herself to the hospital and ordered her own blood work, and from there started her journey with pancreatic cancer. And really it seems to be everywhere, right? It's taken all these lives, and I think it's really important that we look at the numbers that it's impacting now just in the US, but also globally. So about 64,000 people are diagnosed with pancreatic cancer every year in the US. And the average rate of occurrence in the US is about 13.3%, but a little bit higher in the Black community at 15.9%. It's a little bit slower in Hispanics, but certain risk factors such as type 2 diabetes make it higher, often mostly diagnosed in men. The 5-year survival rate is about 12%, which has increased. It was beneath 10% a number of years ago. So we're really happy to see the improvement there. And like I mentioned, similar to my mom's situation, the symptoms are very vague. Most people are, and because of that, most people are diagnosed later in their disease and discover it maybe a little bit too late. The most effective treatment is surgery, but most patients are diagnosed at a too advanced stage to undergo surgery, most commonly known as the Whipple procedure. And at this time, there's really no easy screening for pancreatic cancer. So that's why webinars and like we're doing today and Let's Win are really important to get the information out there about these risk factors and symptoms. So going into where is the pancreas, right? It's located behind the stomach in the upper left abdomen. And because of that, it's surrounded by a ton of different organs, right? Your small intestine, liver, spleen, and the location of it makes the symptoms super vague because you do have all of those organs around it. And it's important to understand those risk factors, especially if you have one or more, and learn to recognize those symptoms, which we'll talk about today. So many patients say after diagnosis, they knew something was wrong, but maybe because the symptoms are so vague in general, it's hard to get to that diagnosis, similar to the situation I spoke to about my mother. So to learn more about that, we have Dr. Shaalan Beg. He's the Vice President of Oncology at Science 37, an adjunct associate professor at UT Southwestern Medical Center, and Dr. Oscar Alvarez, gastroenterologist at Harlinger Medical Center in Harlinger, Texas. And first, we're going to start with Dr. Beg to go deep on the risk factors of pancreatic cancer. And then we'll have Dr. Alvarez join us to talk more about the symptoms. So with that, I'll welcome on Dr. Beg. And thank you so much for joining us today. It's really important for people to understand what the risk factors are and should they get themselves screened based off the risk factors. So what kinds of risk factors are there in pancreatic cancer?
Yeah, there's a lot of data out there, and sometimes it can feel like it's hard to make sense of it all. So before I take a deeper dive in describing what the risk factors are that can increase the chance that someone is diagnosed with pancreatic cancer in their lifetime, I think it's important to put them in relevant buckets. Now, these buckets are not exclusive, and the list of risk factors that we're going to talk about are not exclusive. So there are always going to be individuals who don't demonstrate the typical risk factors who can also develop pancreatic cancer. And at the same time, there will be many individuals who exhibit or possess some of the risk factors we're going to talk about who will never develop pancreatic cancer. But what we're trying to understand here and what we're trying to describe are what are the factors that should make someone aware that pancreatic cancer should be on the list of diagnoses that they and their healthcare team should be aware of. And when I think about the various risk factors, I like to think about putting them in three general buckets. Number one would be lifestyle, behavior-related factors. These tend to be risk factors that could be modifiable, that we may have the ability to change and alter and may have some control over. Not all, but sometimes. The second are diseases and other concurrent ailments that can increase the risk of pancreatic cancer or can indicate the potential for pancreatic cancer. And the third are inherited risk factors, which is increasingly becoming a bigger slice of the pie as we're identifying more familial conditions and more genetic alterations that can increase the chances for pancreatic cancer. So let's take a deeper dive into each one of these buckets. When we take a deeper dive in lifestyle, the first thing that we need to remember is smoking. We know the association between smoking and lung cancer. Smoking is not as prevalent in our society in the United States as it was, let's say, about 30 years ago, but a lot of people who smoked in the 60s and 70s are still around and are now getting older, and that compounds the risk of developing malignancies. So it's predicted that about 25% of pancreatic cancers may be associated with smoking. And the rate of pancreatic cancer amongst people who smoked is 2 times that of people who have not smoked. So for those who are smoking, it's never too late to quit. We know from many studies that the risk of cancer and the risk of diseases such as heart disease goes down the further out you are from your last cigarette, and it's never too late to quit. Next, I want to talk about obesity. There is an association between those folks who fall in the obese category and those who develop pancreatic cancer. I don't know whether we should put obesity in a modifiable risk factor or a concurrent disease bucket, but the point is that that there is an association between those folks who are overweight and the risk of developing pancreatic cancer. Alcohol consumption, both directly from the alcohol consumption itself, as well as through an association with chronic pancreatitis that can complicate the disease course in people who have heavy alcohol consumption, can increase the risk of pancreatic cancer. And like I mentioned earlier, the older we get, the higher the chances of developing all type of cancers, including pancreatic cancer. When I think about the type of cancers that are happening in the United States right now, we're seeing a shift in cancers that were being caused by smoking into cancers that are now being caused by obesity and alcohol. And along with increasing numbers of pancreatic cancer, we're also seeing other malignancies like gastric cancer go up as well due to these changing risk factor profiles. Now, going down further into the concurrent diseases, there's a lot that's been said about diabetes. I already mentioned pancreatitis. Diabetes is very interesting because not only is it believed to be a risk factor for pancreatic cancer, but a lot of folks diagnosed with pancreatic cancer may develop diabetes as their initial symptom of cancer. So that falls not as a type 1 or type 2 diabetes, but is framed as a type 3C diabetes. And we know that people who develop diabetes are at twice the risk of developing pancreatic cancer. And that's probably because the pancreatic cancer was driving the diabetes to begin with. But also important to remember that with millions of people being diagnosed with diabetes every year, most of them don't develop pancreatic cancer. But it's important to think about that in the context of other risk factors that we're discussing. An increasingly identified risk factor, which is increasing in number because of an increased number of CT scans that people are getting for various reasons, are pancreatic cysts. It's not uncommon for us to see in the clinic that someone went to an ER, was diagnosed with a kidney stone, they did a CT, and they happened to see a cyst in the pancreas. And there are many initiatives out there on how to follow these cysts, how to risk stratify these cysts, because most of these cysts may be inconsequential in the life of an individual, but many may be in early signs of cancer or may develop into a pancreatic cancer. And lastly, what I want to talk about inherited factors. We hear a lot about the association of mutations like BRCA and breast cancer. Angelina Jolie from, about 10, 15 years ago was one of the famous celebrities who brought attention to BRCA mutations in breast cancer. But it's important to recognize that mutations like BRCA1 and 2 are associated with other malignancies as well, such as pancreatic cancer. Another mutation is PALB2. And there are a bunch of other associations and syndromes that are associated with pancreatic cancer. And the way I like to think about it to keep my life simple is if we have somebody who has a first-degree family member, meaning their parents and their siblings, who have a cluster of cancer such as breast cancer, melanoma, and pancreatic cancer, that should raise the suspicion of there being an inherited component, when then those folks should see a genetic counselor and be placed on surveillance strategies. Other conditions that are associated with inherited conditions that are associated with pancreatic cancer include Lynch syndrome, which we know has an association with non-polyposis colon cancer, is also associated with pancreatic cancer. We talked about pancreatitis and its association with a gene called PRSS1. Peutz-Jeghers syndrome, also causing colon GI side effects, can also be related to pancreatic cancer. And when it's all said and done, about 10 to 20% of pancreatic cancers are believed to have a familial contribution. This slice of the pie continues to grow as more genetic alterations are being identified, and we need to keep an eye out on the on our individuals and retest people if they've had genetic testing done in the past 3 or 5 years. So what if people who are listening to this webinar identify with one or more than one of the factors that we've talked about? What should we do in that situation? I think it's important for us to increase awareness and talk to our loved ones about the factors that are out there, so we can increase awareness of the risk factors, both the ones that can be modified and the risk factors that could not be modified, because at the end of the day, they are a reality, and these two do associate with one another and can synergistically increase the chance of someone developing malignancy. So know what your risk factors are is the first thing. If you feel like you have the potential based on your family history or your personal history, talk to your primary care physician, talk to a genetic counselor, evaluate yourself for genetic screening, evaluate yourself for pancreas cancer screening. And there are many high-risk pancreas cancer clinics that are developing across the country. See if you can be evaluated in those areas. Most importantly, as we heard Juan describe with his mom's story, be vigilant about your symptoms and be your best advocate. If you feel like something is not right, a lot of the cancer symptoms could be vague, as we'll hear about from Dr. Alvarez. Make sure that you frame the question when you go to your doctor and say, hey, I have a family history of this, and I'm having this symptom, and I'm worried about pancreatic cancer. And if those symptoms are not going away after a couple of weeks, ask to get a second opinion or see a specialist. I hope that covers a lot of the points that you wanted me to cover, Juan. I'm happy to answer any questions.
Yeah, I mean, I think just in addition to that, people who do have elevated risks, have some of these risk factors, how often should they be screened, or how would they best handle those screenings?
So the first thing that I want to say is that there is no approved screening test for pancreatic cancer. So they're unlike mammograms and colonoscopies and pap smears that we have strict guidelines or recommendations on when to start these screenings and how frequently they should be done. There is no approved screening test, no blood test, no imaging test to screen for pancreas cancer. So what that means is that the answer to your question has to be individualized based on the risk factors that somebody has, based on what their scans look like and what their personal risk factor looks like. But the first step is to be evaluated for these conditions and then come up with a plan with your healthcare team on, will it be a blood test? Will it be MRIs? Will it just be a clinic check for symptoms? All of these are very appropriate ways to evaluate for pancreatic cancer.
And then if you're a few steps before that, right, and you're trying to encourage patients, maybe you come into contact with a patient who maybe lists this into their history, but hasn't brought it up to you as something that's a potential risk for them in the future. How do we encourage that genetic testing or any testing for that matter for people that have that family history?
Yeah, you bring up a good point, because once someone's been identified with a high-risk feature, it seems like the next steps are pretty obvious. And So two answers to your question. First of all, if you test negative for any of those genetic conditions, that doesn't mean that that somebody may not develop pancreatic cancer. So we don't want folks to have a false sense of security if they don't have an identified factor either. We still need to keep a vigilant eye on such folks. But to answer your question, it's very challenging to drive uptake for mutation for pancreatic cancer screening and for inherited conditions. Those factors can go from, number one, lack of awareness amongst the physicians, lack of awareness amongst patients about their family history, lack of availability of tests, lack of coverage. Will insurance pay for my test? Or what if I get the test done and now insurance won't pay for follow-up tests? And there are tools out there, and there is reading material. There's reading material on the Let's Win website as well, which can help individuals see where they fall and take that material when they go to see their physicians on their annual visits and have that conversation. And that's where a lot of those aspects should begin, because that we want to set people up for success. And it's not just about getting the test, it's about getting the right test at the right time and ensuring that we have the right follow-ups that individuals need as well.
Yeah. Thank you, Dr. Beg. Yeah, a lot of what you said rings true. You know, the follow-up nature of it, being your own advocate. I know that was something that was really important in my mom's situation, and, you know, having not only herself, but, you know, her family, myself included, around her to be that advocate in the process, which is so important. So thank you so much for bringing up the topics around increased risks and kind of understanding all the risk factors that go into pancreatic cancer. I did want to jump over now to Dr. Alvarez and welcome him to the stage to discuss a little bit about the symptoms. But thank you so much, Dr. Beg. Awesome. Dr. Alvarez, thank you so much.
Thank you.
Let's do it.
Much. Good afternoon, everyone. Thank you very much for this kind invitation. It's an honor to be here and sharing with you some thoughts about this interesting topic. Well, good job done, Juan and Dr. Beck. Tremendous introduction to the risk factors. Is very clear, very concise. Thank you very much. Well, about symptoms, I just wait. What do you want to know?
Yeah, I think there's a lot of instances where, you know, people go into a primary care physician or a gastroenterologist and they see people with chronic indigestion or pain. Maybe they're not sleeping well, as I brought up, you know, in my mom's case. So how do you really determine the cause? And are there any certain signs that maybe raise a flag for you to say, hey, maybe this is pancreatic cancer? How do you help physicians identify that?
Yeah, that's a very, very interesting question and very complex. You know, as you said at the very beginning, when you did the introduction where the pancreas is located, and you very clearly say there is a ton of organs around the pancreas, and that's what it is. Every one of them can induce pretty much about the same symptoms. So that's what things get a little bit complicated and complex. But to tell you the truth, there is no a single set of symptoms that points toward pancreatic cancer. But what I have to say, taking in consideration the presentation of Dr. Beck, you know, this is multiple things to be considered together. It's not only one single thing apart. And talking about that is, yes, there could be certain signs that could point out towards pancreatic cancer, but the most important part is to have everything together. And let me explain you that. Very important. The first part, very important part is good medical history. It needs to be very thorough. In the sense that we are talking about your mother, Juan, I also lost my aunt, that it was like a second mother to me. Those symptoms that have been coming on and off for years, okay? The important part there is try to associate those symptoms with risk factors, like the one that has been already been described. Those risk factors are like a red flags. And together with the symptoms of the patients, we can more thoroughly get an approximation that that's one of the things that it could happen. So physical examination is the second part, very important. Medical history, talking about symptoms, talking about risk factors. Physical exam is very important to see if there is any masses that you can palpate in the belly, see if there is any tenderness in the belly, tenderness on the back, see if there is any signs of jaundice, which is yellow color of the skin, the eyes. Try to see if there is any weight loss, unintentional weight loss, if there is any lack of appetite, any other of those signs that I can point out together with the other part of the history towards pancreatic cancer. Having said that, with all those patients that initially came with those vague symptoms, digestive symptoms that they are not specific of any particular disease, we can start the workup in the sense that we can do some blood tests, checking liver tests, checking blood tests for anemia, things like that, elevation of the pancreatic enzymes in case that patient has some history of suggestive of recurrent pancreatitis. In addition to that, we had imaging studies at the very beginning, talking about abdominal sonogram, which is a very common test that we use in those patients with vague symptoms, abdominal discomfort, looking for pancreatic disorders, liver disorders, gallbladder disorders, but try to focus into the pancreas in case that they have the red flag signs, as we talked about that before. We can use computer tomography, we can use magnetic resonance tests, we can use endoscopy, we can use endoscopic ultrasound. We also can use endoscopic retrograde cholangiopancreatogram in case of specific disorders. And if there is any specific things finding one of those ancillary tests, like a pancreatic lesion, pancreatic mass, pancreatic cyst, we'll focus in tissue sample to try to get a more approximate diagnosis. So to conclude this, I would say is altogether symptoms, physical exam, and risk factors, the one that they are going to point out towards a specific problem with the pancreas. And let me say this, very important. Besides the risk factors, very important, weight loss, jaundice, personal history of pancreatitis, and in addition to that, patients that have been diagnosed with new onset diabetes at all age. That's an important sign there. So that's pretty much, I think, to make that concise. And that's the way that probably we can start in those patients.
Yeah, that's great. Super, super helpful. I think, while there's no standardized test at this point, there's a lot of tools at your disposal, as you mentioned, Dr. Alvarez, in terms of how to pinpoint exactly what's going on. So very helpful to understand that. And then in terms of those specific symptoms, are there ones that you see more often that end up leading to a diagnosis than others?
Yeah, that's a good point and good question again. And I refer to this again. Pancreatic cancer is a silent killer. That's the bad part about pancreatic cancer, and that's the reason we have so many deaths induced by this killer disease. And the reason of that is because usually we don't have any significant signs at the very beginning or at the very beginning stage of the pancreatic cancer. But having said that, I will consider the following. Abdominal pain is a very important sign. And most of the pain in these patients, it could be coming like a discomfort that is constant, progressive. That's an important description there. It's something that is a discomfort or pain that is progressively getting worse. In addition to that, that pain can be radiated to the back, or the pain could start in the back instead of being in the abdomen. And in addition to that, I will say another few things to pay attention to at the very beginning is unintentional weight loss, lack of appetite, even though weight loss and lack of appetite could be with any cancer, putting that together with the things that we have discussed before, it just help us to focus in pancreatic disorders in those patients. In addition to that, jaundice, again, yellow skin, yellow sclera, yellow eyes, pale stools, meaning that there is a blockage in the bile ducts, like probably what happened in your mother when, you know, the stools became pale because there is no bile. The bile has been accumulated because of the obstruction. In addition to that, you know, all kind of different digestive problems, nausea, vomiting, diarrhea, indigestion, things like that, that is becoming progressively worse, point out that something is going on there. And we just have to seek attention for those patients, a deeply evaluation of those patients, taking in consideration if they have risk factors plus these type of symptoms. It can guide us a lot better that we need to investigate them. And that's the important part for the primary care physicians, which are the important beginning. The beginning evaluation of the patients start with the primary care providers, and they need to be conscious about those digestive symptoms plus risk factors in order for us to get an early diagnosis of pancreatic cancer.
And early, like you said, is such a key element of beating pancreatic cancer. And starting early, how do you know, is there generally a symptom that is kind of the tipping point of like, oh, I think this is the first step in, you know, diagnosing pancreatic or getting towards pancreatic cancer? Is there anything that you see that comes up more often earlier in the stages versus later?
I would say that sign, for instance, new onset diabetes is an important sign just to be taken in consideration, especially for those patients that have been diagnosed at old age. That's a very important key there, an important sign. I would say in addition to that, the abdominal pain is another key marker from the very beginning that it points towards looking something in that area of the pancreas. In addition to that, as I mentioned before, weight loss and lack of appetite will be another signs to look early on. We are talking about a stage 1, a stage 2 pancreatic cancer. Those are kind of symptoms that can happen in those earlier stages.
That's super helpful. And then if anyone is experiencing those, where do you recommend patients get screened, or what kind of testing you recommend? I know you brought up a lot of different tools that you can have at your disposal, but where do you recommend that they start in terms of screening?
Yes. Remember two things here, Juan. This is very important, what I'm going to tell you about it. We have to make the distinction of diagnostic imaging studies versus screening. So when we refer about a screening, is because we already know that that patient could have risk factor for pancreatic cancer. And that's a totally different ballgame. Diagnosis one is we have patients with those symptoms that point out that we should further investigate that with computer tomography, MRI, blood tests, and so on, so far, so on. But having said that, there are two things here before I go to the specific test for screening. Those patients that they have those particular symptoms, if they have been in progression, symptoms that they are recurred and they are getting progressively worse, and in addition to that, there is risk factor for the pancreatic cancer, like genetic issues and things like that. Important for those patients to be referred to the gastroenterologist, very important, to the oncologist, or to have genetic counselors or programs that they deal very well with pancreatic cancer screening. And I said primary care physicians are very important from the very beginning to start what is needed at the very beginning early on. One of the issues that we have is, for instance, what happened to your mother, what happened to my mother, they continue to have some digestive complaint symptoms, and they just saying that could be irritable bowel syndrome, that could be some biliary dyskinesia, problems with the gallbladder, or any issues with the colon, you know, just because there are many organs, you know, in that area. But I
Right.
say it's very important with those symptoms, don't change or they're recurring, just to go and consult all these particular physicians. To answer the last one, what kind of screening test? We're not talking about diagnostic, a screening test that already we know that patient has symptoms plus the red flags, like the risk factors. There are two tests that they are very important, two ones that we use the most. One is endoscopic ultrasound, which is a device that gastroenterologists we use very commonly. And this is a device that it looks like an endoscope. It has on the tip the probe for the ultrasound, and that's the reason it's called endoscopic ultrasound. You can do a combination of endoscopy plus ultrasound, and the images that you get are similar to the ones that you get with ultrasound, but they are very proximal to the pancreas and all the organs next to the pancreas. So it's a very important tool with very high sensitivity and specificity, even though for lesions less than 3 centimeters in size. So this is one of the most important tests to be done in those patients to be screened that we already know that can have some symptoms plus some red flags. And the second test that we use the most for screening is magnetic resonance. That is combined what is called MRCP plus MRI. That means we take a look of the bile duct, the pancreatic duct, and the pancreas itself with that kind of imaging study. Those are the two most important tests that I would say that. And in addition to that, for screening, you know, we can do tumor markers like CA19-9, but that's really not been approved for screening. Genetic testing is important, as Dr. Beg described that before.
Well, thank you so much, Dr. Alvarez. Yeah, on that note of genetic testing, if anyone wants to go a little bit deeper than we went today, please visit the Let's Win webinar page to view the October 11th webinar, where we went deep on the BRCA mutations and pancreatic cancer. But thank you again, Dr. Alvarez, and thank you, Dr. Beg. Now I'll welcome Dr. Beg back so we can go into the Q&A. It looks like we already have a couple questions in the chat. So thank you so much for your participation and engagement today. We'll start with Nancy Perez. First question. She mentions going to get an annual blood test to check her pancreas. Is that a good strategy?
Dr. Beg?
I think in terms of annual blood tests to check the pancreas, I guess if we're talking about blood tests to identify pancreatic cancer, there are two that come to mind. One is CA19-9, which is a tumor marker which can be elevated in people who have pancreatic cancer. That is, however, not a test that is extremely reliable to diagnose pancreatic cancer. And I do not recommend people, unless we're seeing a mass or have already had a biopsy-proven cancer, to have that test done. There are aspects that test can tell us in terms of effectiveness of treatment or cancer recurrence down the line. I'm curious, Dr. Alvarez, if you recommend that for the workup of pancreatic lesions, but there is an emerging role for circulating DNA markers for early detection of multiple cancers, and there are some clinical trials looking at some blood tests that look at cancer DNA fragments in the blood. And that may be a way to diagnose cancers early. There are tests in lung cancer, colon cancer, as well as pancreatic cancer in the market, but those are only available through clinical trials. But I'm curious how you advise your patients who may come in with a concern for cancer and getting blood tests.
Dr. Beg, thank you very much. No, I concur with you very much. I think I agree with you 100% of what you say. I would say sometimes we follow the guidelines of the different societies, the American Gastroenterology Society or the American Cancer Society, and patients that we estimate that they had a high risk for pancreatic cancer. In those particular patients, we proceed with the endoscopic ultrasound. And what usually we tell the patients, that test start to be done at 50 years of age, the first time. And the recommendation is probably to do one of those every year. But as you say at the very beginning, Dr. Beck, very difficult for insurance companies to be covering that in a yearly basis. There could be a significant problem there because there is not that gold standard screening test for pancreatic cancer, unfortunately. The other issue is we proceed with endoscopic ultrasound in those patients with high risk, and we start below 50 years of age because we can go 10 years below the age in which the first relative, first degree or more first degree relatives or second degree or genetic testing with the high risk for pancreatic cancer, we start 10 years below that margin. And depending of other inherited conditions that they can be starting early on, sometimes we can start with endoscopic ultrasound between 35 and 40 years of age. So that's pretty much endoscopic ultrasound is a good one. In the other hand, the different ball game is in those that have been found to have pancreatic cysts, as Dr. Ben mentioned it at the very beginning, especially those ones that they could have a higher risk for pancreatic cancer. Endoscopic ultrasound could be done every 3 or 6 months, at least, depending on the evolution of that pancreatic lesion.
Yeah, Nancy clarified that she's been doing the endoscopic ultrasound for the last 15 years, as well as a new blood test. So it sounds like standard of care is being upheld. So thank you for the question, Nancy. We'll move on to Gloria's question. And she mentioned that her family doctor has only offered an annual abdominal ultrasound. Both her mother and younger sister have died of pancreatic cancer, and she's worried. She's had genetic testing several years ago, but tested negative. What else should she do to track this down? For either Dr. Beg or Dr. Alvarez.
Well, I'll make an editorial statement. We're already seeing how different physicians are proposing different surveillance strategies for people who are concerned about pancreatic cancer. And that doesn't come as a surprise because we don't have that one ideal test, either a blood test or imaging test, to screen for a pancreatic cancer. But kudos to the folks who are talking to their doctors about pancreatic cancer. And in my experience, keeping that on the differential and thinking about it already dramatically increases the chance of diagnosing cancer earlier than in situations where it isn't. So just by the process of having that conversation, it's extremely important. When we think about different tests, I think it's important for us, Dr. Alvarez, to also talk about the risks of overtesting and why there may be some hesitancy from some practitioners to just order a CT or order other tests. And the reason I believe, Dr. Alvarez, you mentioned ultrasound and MRI as opposed to CT scan is because the ultrasound and MRI does not give radiation exposure. But we do know, and the couple of things that come to my mind with extra tests are what we call incidentalomas or lesions or spots that may have been inconsequential and lead to extra burden for our patients. And of course, the fact that an MRI can be burdensome, both financially and physically, for such individuals. But, I applaud the person asking the question for speaking, for being aware of their family history and speaking with their doctors. I cannot fault anybody for whatever proposal they give their patient for screening because there is no single perfect test out there, but you're getting the testing done, you're seeing a physician and you're having discussion on imaging. That's a wonderful start. But I think Dr. Alvarez, I'll pen it off to you on that.
Yes, thank you very much. I agree with you again. This is what I would say, this is an important part. You have not only to see the symptoms, but also the other red flags, the risk factors. And I would say for those patients that really are categorized as a risk factor, high risk factor for pancreatic cancer plus some symptoms, the best way to screen those patients is not with an abdominal sonogram. I would say that either is going to be endoscopic ultrasound versus MRI. Those are the two most important tests to do that. Again, not for common symptoms. We're talking about both together. Risk factors for pancreatic cancer plus symptoms. The best way to screen those patients is with endoscopic ultrasound and MRI. But this is the catch. MRI is more readily available in multiple different places. Endoscopic ultrasound is more difficult to get it. That's usually get in specialized centers, but you don't get it everywhere. So that's the reason MRI became a very important tool to get those patients that they have those risk factors plus symptoms just to be testing for pancreatic cancer. I would not go with abdominal ultrasound every year because, you know, abdominal ultrasound is not very specific, it's not very sensitive compared with MRI and endoscopic ultrasound. Did that make answer to your question?
Yeah, Gloria, let us know if you have any follow-ups on that
No.
question, but thank you both, Dr. Alvarez and Dr. Beg. We have one final question here, if there are no others in the chat. If there's no official blood test to screen for this cancer, are there blood test markers that perhaps a GI specialist might conduct if there are symptoms?
That
Yeah,
goes to you, Dr. Alvarez.
Yeah, no, again, you know, just to put that in perspective, we need to put everything together. That's the important part there. Is crucial to put all the pieces together. It's not only symptoms, but also the risk factors that we had already discussed, plus family history, plus issues with genetic conditions, or the family history of different type of cancers, colon, breast, kidney cancer, things like that, that it makes you to focus those patients in a better way, more specific for a screening test. And that particular ones, those are the ones that I recommend very highly to use: endoscopic ultrasound, MRI. Those are the tests that they are gonna give you the best answer to what you are looking for. For other inspecific symptoms, digestive symptoms with no risk factor for pancreatic cancer, the usually test that we use for those patients is blood test, regular blood test to see if there is any abnormalities with the pancreas, with the liver, or abdominal sonogram just to do an initial scanning to see what is there. Endoscopy to be sure that you don't have any ulcers in the duodenum, in the stomach, or any other lesions that could explain those symptoms. And then you start to go deeply into that.
Awesome. We have one more question here from my dad. How old is an old age diabetes diagnosis?
Yeah, that's a good question. Remember, most of diabetic patients, remember, diabetes is a very genetic condition. And most of the patients are diagnosed early on. We're talking about below 50s, you know? So if you start to have new onset diabetes about that range of age, 50 and above, that's a sign to be careful with that you could be could be pancreatic cancer, the one that is inducing that diabetes. So that's the point there. I don't know if Dr. Beck has any other issue there. But...
Yeah, and another one that seems to come together quite a bit is new onset diabetes with weight loss. Now, certainly, a lot of people with diabetes can have insulin resistance at the time that they are diagnosed and have glucose toxicity and can have weight loss because of that. But if someone reports more than 10-15% weight loss around the time of also being diagnosed with pancreatic cancer and who's older, those are they should raise red flags.
Got it. Thank you both so much for those. I think that concludes all the questions we have for today. Just wanted to summarize very quickly. You know, we want to make sure that you're aware of the common risk factors and common symptoms. Thank you both, Dr. Beg and Dr. Alvarez, for going deep into that. Of course, we have a ton of resources at our disposal, whether it's Let's Win, the Lustgarten Foundation, Pancreatic Cancer Action Network, American Cancer Society, Cancer Care. All of these are great resources to keep you informed on latest and greatest information on the risks and the associated symptoms of pancreatic cancer. But I'll pass it back off to Cindy just to wrap things up with us.
Great, thank you. Excellent. Sorry, I thought I was muted. Thank you, Juan, for moderating a wonderful session with Dr. Beg and Dr. Alvarez. We're grateful for all your support on this initiative and many, many more. I also want to thank our partners from the National Alliance for Hispanic Health, as well as our sponsor, AstraZeneca. For more information, as Juan shared, we have a tremendous amount of resources on Let's Win Pancreatic Cancer. And all of that information, just to remind you, is available in both English and Spanish and is all medically vetted. I hope you'll join us on November 8th. We have a webinar at the same time, 2 p.m. Eastern, focused on treatments and clinical trials, including a discussion on why it's so important to have everyone represented in trials. So I hope everybody has a good day, stay safe and healthy, and we hope to see you in a couple of weeks. Thank you.